Thank you for the introduction. I'd also like to thank the organisers for the invitation to speak on this topic. As I said, this presentation was based on the work conducted for a Masters of Nursing and Research and the systematic review on lateral position, which has been accepted by the Cochrane collaboration. I would also like to acknowledge before I start my colleagues in this project, Professor Tracy Bucknell from Deakin University School of Nursing and Midwifery, who was my supervisor and co-author, and also David Glanville and Nadine Ferroni, who are co-authors as well. In this presentation, I plan to sort of briefly describe the context of using body positions for respiratory management. The talk is actually limited to manually applied body positions and not continuous rotation or using automated bed on a continuous arc. I will present the findings of the overall findings of the systematic review on lateral positioning, because we compared the side-lying position with other positions such as supine, prone and semi-recumbent. We included lots of positions as potential comparators. And I'm also, based on the review, I'd like to highlight standard positioning practice and whether it actually exists, and then put forward where do we go from here, and just for some interesting information about where we might see ourselves in the future. At the beginning of the 20th century, posture to aid expiration of primary secretions included tilting patients into an almost vertical position with the head down for a few minutes, several times a day. And variations of the jackknife position was proposed as the intermittent postural drainage position. And these reports actually predate literature that actually recommended turning and repositioning schedules for respiratory management. So quite severe. I don't know if we'd use those positions in ICU today. But in the 1930s, Nelson, a thoracic surgeon, wrote a paper calling into question the effectiveness of these intermittent inverted postural drainage positions for clearing accumulated secretions, particularly that were lower than the trachea or the primary bronchus. And he acknowledged that the head down position was distressing and probably impractical for acutely ill patients. He ended up advising 7 different body positions for draining 7 subdivisions within each lung based on x-rays, as well as clinical examination. And the proposal was that the affected lung was uppermost in each of the body positions, allowing gravity to actually drain any purulent bronchial secretions. And he recommended each position was at least delivered for 3 periods of at least 2 hours during the day and for the greatest part of the night. But interestingly, for those patients who had 2 or more affected areas, he suggested that the lateral position, being halfway between prone and supine, was most useful. And this report was probably one of the first references to lateral positioning schedule for pulmonary secretions. But are we any further advanced in knowing what the best body positions are to use for respiratory conditions? So if we fast track to today, much has been reported about mechanically ventilated patients at risk of ventilator-associated pneumonia. There's over 200 potentially relevant reports examining if the semi-recumbent position versus lying flat or supine reduces aspiration of gastric contents and its association with lower risks or lower incidences of VAP. But over the last decade, evidence-based clinical guidelines for prevention of VAP have also included the semi-recumbent position in their recommendations, with recent focus on strategies to get nurses to adopt this position in a more consistent basis. And our clinical environments and our guidelines and consensus groups have actually conceded that the original studies that actually looked at the semi-recumbent position at a 45-degree angle is probably unachievable, and that 30 degrees is more practical and perceived by nurses as being more comfortable for the patients. However, Neil Weiss, when they did their systematic review and consensus panel, actually only found, of all those 200 studies, that there was only 3 that were randomised trials. And when they pulled their data in that statistical summary called a meta-analysis, that Brendan talked about, they concluded that there was uncertainty whether the 45-degree head of bed elevation was actually effective or harmful in regards to the occurrence of VAP, ulcers and mortality. And to date, that research evidence, the study here, is the only study to suggest that there's actually a difference. But the rigour of this study has actually been critiqued as less than ideal. So why clinicians are reluctant to lie their patients absolutely flat, because there is a trend that intubated patients may be more at risk of gastric aspiration. The risk of VAP has not been established as a positioning strategy or established for positioning strategies that involve more than one body position. In particular, whether it has not been established for side-to-side rotation. Furthermore, the theoretical premise for lateral positioning, whether it's side, back, side, or variations of this, has not been challenged over the years, as patients left immobile in any body position for long periods of time are considered at significant risk of dependent airway closure, atelectasis, pneumonia, as well as arterial desaturation, in part due to the accumulation of bronchial secretions. So in conducting the systematic review, what we were interested in is finding out whether there was any evidence of when not to turn a patient, and what were the best positioning strategies to optimise respiratory management in ICU patients. So our objective was, what is the effect of lateral positioning compared to other body positions on morbidity, mortality and clinical adverse events? We used clinical adverse events as a primary outcome. We considered and defined those clinical adverse events as incidents of hypoxemia, hypertension, profound refractory hypertension, arrhythmias, inadequate oxygen delivery, and global indicators of tissue oxygen impairment, as well as any other indicators of hemodynamic compromise. We actually chose to include these as primary outcomes, as we are constantly monitoring these variables in ICU to avoid life-threatening hypoxia and hypoperfusion. And treatment is actually changed and instigated based on the presence of these clinical adverse events. We limited our inclusion to only randomised trials, including crossover studies, as well as quasi-randomised trials. For crossover trials, what occurs is that every participant receives all treatments, and most of the studies that we found were comparing right, left, lateral position and supine position. So in effect, a single patient receives all treatments, but the sequence at which they receive each treatment is actually randomised. We were specifically looking at the single use of each body position. In other words, for lateral position, that was right, left. For those with unilateral lung disease, that was good lung down versus bad lung down. And for bilateral lung disease, when studies actually specified it, it was worse lung down versus better lung down. We are also interested in the repeat use of lateral positioning within a positioning schedule over a period of time, and we called that lateral positioning. So, and that was to examine morbidity and mortality. We did plan to conduct a subgroup analysis, but unfortunately there was not enough similar studies to conduct this. Our search strategy included 9 databases, including Medline, Synel, central databases. We did hand searching of references, and we also hand searched 2 journal articles, the Australian Critical Care and the Australian Journal of Critical Care, which were not in the Cochrane's master list of hand search journals. We had no language restrictions. We screened over 3,500 articles, and that comes down to the multiple terms that are used for positions. 160 of those were assessed for eligibility. 37 articles were included, and after duplication, there were actually 24 studies. The sample size, which is very disappointing, were anything from 9 patients to 120 patients, with the average being around about 36 patients in each trial. So we looked at 2 separate comparisons. There were 22 studies looking at the effect of turning. The majority of these examine outcomes at 15 to 30 minutes after turning, with a range of 10 minutes to 2 hours. There were 4 parallel group studies, and there were 18 randomised crossover trials, and all of them examined mainly variables common to monitoring ICU patients, such as oxygen, blood pressure, cardiac output, and mixed venous saturation. Our main finding with this is that we weren't able to extract sufficient data to actually do a statistical analysis, except for one outcome, which is partial pressure of oxygen as a measure to detect hypoxemia. And we were only able to do this for the trials that actually specified that they were examining unilateral lung disease. And of interest also is that all but one study were methodologically weak. There were lots of dissimilarities in trial design. The angle of rotation also varied greatly, from 20 degrees lateral rotation right through to 90 degrees, with half of the studies actually placing their patients at a 45-degree angle. There was also variations in the lateral position as well as the supine position for the head of bed elevation as well. But what was also interesting in our search was that there was only 2 studies that examine lateral positioning as a repetitive therapy. And there's a lot of healthcare literature that actually cites these 2 studies as trials, cites these 2 trials as evidence for recommending frequent turning over immobilisations. Both studies were conducted 24 hours after coronary artery bypass surgery. They were only turned side back side for 24 hours and compared to supine immobilisation. Both studies concluded that frequent changes in body position were beneficial based on their findings of having a statistical difference in the number of hours with fever at 1 day and 3 days, and the length of stay. But due to the way that the results were presented, we were unable to pull any data for meta-analysis with these 2 studies. In addition, there were lots of methodological issues with both studies. So there is uncertainty about whether lateral positioning, conducted under strict conditions in terms of 2-hourly turns or similar, actually reduces pulmonary morbidity compared to other positioning practices. But looking at that one meta-analysis that we were able to conduct, it was a measure to detect hypoxemia, and we defined all our clinical adverse events. We actually gave them critical thresholds, and for partial pressure of oxygen it was less than 60 to define hypoxemia. And in this study, they actually, the comparison was between 10 to 15 minutes after turning. There were 2 crossover trials. Patients had a range of unilateral lung disease diagnosis, from unilateral pneumonia, edema, contusions, pleural effusions. Only one of these studies actually had all the patients mechanically ventilated and sedated. And the summary effect was that there was a definite mean difference of around about 50 millimetres of mercury in terms of the difference between bad lung down and good lung down, of course favouring bad lung down, but only one of these studies actually had their mean of, that met the criteria of hypoxemia of 59 millimetres of mercury. But in saying that, this study actually included 3 patients on room air. So there was actually, in terms of generalisability, it's not clear that we can, in terms of looking at critically ill patients. The strength of evidence is very weak. The finding itself does not address whether sustained use of the good lung down in unilateral lung disease, in the presence of even an initial beneficial effect, is actually counterproductive over time. It is also noteworthy to note that there are observation and randomised studies that have actually reported that some patients actually have a paradoxical effect, that they actually have worse partial pressures of oxygen with good lung down and better partial pressures of oxygen with bad lung down in those initial stages following turning. But we don't know if this paradoxical effect is actually common or rare. So our conclusions for the actual systematic review was that there was actually insufficient data to draw conclusions and the quality of the evidence was actually poor. So we were unable to make any clinical practice recommendations. We identified sort of research gaps. No studies in the search strategy were located that actually examined lateral positioning interventions greater than 24 hours. There was no studies that actually identified lateral positioning versus prone or lateral versus semi-recumbent. And prone positioning is, as a comparison, is of interest because we know that regularly turning to a lateral position is less labour intensive than prone, and it may be associated with fewer complications. But we just don't know if lateral positioning is actually worse than prone for improving oxygenation, preventing morbidity and reducing mortality, because the studies are not there. And if we look at the prone research, continues to compare prone versus supine positioning with no mention of turning to a lateral positioning or 2-hourly turns. And previous systematic reviews and meta-analysis suggested that, yes, there was an improvement with prone in oxygenation, but there was unclear if there was any difference in mortality. There was no difference found. But recently, Lee and colleagues have just published this year a systematic review meta-analysis that they reported reduced rates of mortality in the prone group. But the studies in this systematic review were actually dissimilar from the perspective of the type of patients and the trial design, which they actually acknowledged in a subsequent report this year. Bloomfield and Noble suggest that when they did their analysis on that systematic review, that there was actually only one study, the Prosever study, which had the substantial impact of reducing mortality. And of interest, though, in the Prosever study, is that the supine group were actually in the semi-recumbent position. And the study sites that were used, conducting prone, had actually been conducting prone on a daily basis for over 5 years. So I don't know how transferable that is to our environments. Because one of the major criticisms of adopting the prone position as a therapy is the contextual issues, without substantial evidence that it's a beneficial effect in the majority of ARDS patients. Prone positioning is labour intensive, it requires considerable resources for safe delivery and may have a higher incidence of complications. We'd think that simpler therapy are more likely to be consistently applied, but we just don't know if strict 2-hourly lateral positioning is as effective or not effective as prone positioning in ARDS patient. So many positioning trials, whether it's prone, semi-recumbent, or lateral positioning, tend to have variations in their duration, the angles of rotation, the procedures within the positioning trials, which makes comparison very, very difficult, as we don't actually have standards for each of these body positions. And what is the standard in 2014? While the origins of the 2-hourly turning is unknown, it's unlikely to be standard now, because we know that adherence to the standard is probably low and has been reported by lots of observational studies and surveys of nurses about what their actual standards of practice are. And in the past, the International Pressure Injury Prevention Guidelines actually recommended turning every 2 hours. But this recommendation was withdrawn in 2009 when they actually put the wording that the International Clinical Guidelines for Pressure Injury Prevention favoured repositioning schedules that consider the patient's condition and what support surfaces they're on. In other words, very vague. That less frequent turning on specialised mattresses was a consideration. But we're unclear whether these new support surfaces, including the alternating pressure airway mattresses, are influencing our decision not to turn patients as frequently. And the rationale of the current trend of repositioning delays of greater than 4 hours in ICU is unclear. Is it due to convenience or custom? Is it because of the uncertainty of what to do in the presence of respiratory or hemodynamic instability? Or is it because we have very heavy workloads now and we have lack of resources and there's an occupational health and safety issue when we have concerns for moving our extremely heavy patients, which may lead to less frequent turns? We may find it also difficult to adopt evidence-based guidelines when we don't actually consider these contextual issues around the change of practice. And when guidelines focus on one outcome only, we can get conflicting recommendations, as we do for the backrest positions. The pressure injury prevention guidelines suggest that ICU patients should be less than a 30-degree angle of head elevation, whereas the VAP guidelines actually suggest they should be greater than the 30-degree guidelines. And the evidence-based guidelines for VAP prevention do not actually include side-lying positions, but we apply the head of bed elevation to 30 degrees in this position anyway. So where to from here? Of particular interest this year is for the future is one study that is currently in progress called the Gravity VAP trial. It is a prospective, multi-centred randomised trial being conducted in Spain, Italy and the US. It's enrolling 800 patients that are intubated and mechanically ventilated to compare the efficacy and the safety of the lateral Trendelenburg position versus the semi-recumbent position in preventing the incidence of ventilator-associated pneumonia. The rationale behind this study is based on laboratory work and observational studies, and that actually found that the tracheal orientation of the ET tube below the horizontal can actually prevent aspiration of the oropharyngeal contents across the ET cuff and allow for natural drainage of secretions away from the airways. And in the lateral Trendelenburg position, they're only doing 5 to 10 degrees, mainly around the 5 degrees head down, side to side every 6 hours. And they're allowing for patients to be in the supine position to actually facilitate getting to the other side. Their entire duration of the study is 36 months. Of the 800 patients, they've enrolled less than 300, about 290. And they are looking at the patients until they're either extubated or at the end of 14 days of study. And they're enrolled 12 hours, within 12 hours following intubation. So this is going to be interesting to look at the fact that whether we should consider going back to either lateral horizontal to allow for the secretions, the oral secretions, to actually not be migrated into the lower respiratory tract, or whether we should actually facilitate their removal. But in terms of nursing and turning, nurses are concerned about whether it's safe to turn their patients when they're unstable or have labile blood pressures or SATs. But until we have research evidence of good quality studies, clinical decisions about whether to return the patient immediately to a more horizontal position or semi-recumbency when physiological variables become labile needs to be considered on a case-by-case basis and reference to local guidelines that are of acceptable parameters. And here I've just shown you one such local guidelines that's been developed in the last couple of years by a group in Virginia, America. They used a review and a consensus panel within their local large trauma centre, which had multiple ICUs. And they developed this because they wanted to stop the knee-jerk reaction of stopping to the turning intervention, particularly for pressure injury prevention, when patients were perceived to be hemodynamically unstable. And one of the panel's recommendation is to highlight the concept of a recovery time after return. And that means returning back to baseline figures. And they suggested that on average, most of our ICU patients, it's acceptable for them to actually return within 10 minutes before making a decision whether not to turn or to turn them back to their back. Their recommendations was to go slow, do 15-second increments of 10 to 15 degrees and pausing, with multiple staff to allow for slow turning and management of equipment, with the patient's response monitored at each stage and care individualised based on their response to trials of turns, with at least one trial 8 hourly in patients deemed too unstable to turn. And based on these guidelines, they were able to, in their ICUs, reduce their hospital-acquired pressure ulcer rates from 8% down to 2.4%. There are significant research gaps on patient positioning, with more questions than answers. But the effect of lateral positioning on morbidity, the consequence of delays in turning patients, and the recognition that clinically important signs of hemodynamic and respiratory instability on turning are all important clinical considerations, actually requires further research to actually resolve. Thank you.